case
Jawad,
join.
Jawad is joined. Okay, sir. Okay, sir.
Jawad, can you please share your slides and see how it goes? Jawad, please unmute Dr. Jawad.
So
Jawad, unmute.
good evening. Yeah, good evening, sir.
Good evening. Please try to share your slides.
Yes, sir.
Jawad, is your internet connectivity good?
Sir, internet control is good, sir. Sir.
Okay, okay. Start sharing.
So it's showing so 1 minute, sir. Showing a unsupported document. A few minutes.
You are connected through which device, Dr. Jawad?
Sir, tablet,
Jawad?
sir.
Okay.
Hello, sir.
Now, are you able
Sir,
to
tab,
see
sir.
are you able to see the icon or tab
Yes,
bar?
sir.
Sometimes getting the problem. Are you able to get the icon saying that this screen share?
No, it's not showing, sir. Screen share, yes, sir. It's showing a start screen.
Yeah. Click on that. You'll
Yes,
get
sir.
connected to the desktop. There you try to select your slides area.
Start share, sir.
No, share with the green arrow mark looking down.
No, sir, it's not showing.
Icon,
Sir,
are you able to see?
no, sir, it's not showing, sir.
Otherwise, control differ some other device because sometimes you have seen
Okay, sir.
people developing, but it is there. Share.
Jawad, ask
Icon.
this or Jamil. They did very well, Jawad. So ask
Okay,
them
sir.
which device they did. Quick. Ask them to
Okay,
go
sir.
to
Okay,
their
sir. Okay,
device
sir.
and share.
Okay. No, okay, sir.
You're in Harrison Ola.
So he got disconnected, sir.
Last time they too did very well. I do not know. I'll just contact them, sir. Contact them.
Yeah, he got disconnected now. Nicole is Java's device. Yeah.
This is okay.
Javad?
Javad.
Good evening, sir.
Yeah.
Sir, good evening, sir.
Yes,
Yeah.
yes. This is okay. This is coming. Presentation is coming.
Nice, sir.
One
Sir, can I
minute.
present the case, sir?
Go to the first
Sir?
slide, Javad. Go to the first slide.
Okay, sir.
CVS case presentation. Yeah, correct. Just let this be here. You stop using your video. Only audio is enough.
Okay, sir.
Because your connectivity is bit of slow. If you're going to use your video, you'll get take away further connectivity problem. So
Sure, okay.
just the CVS case presentation. Dr. Chakravarti sir is joined. Good evening, sir.
Good evening, sir. Good evening.
Yeah, I am Dr. Saravanan from Coimbatore, sir, coordinating this
Good
work.
evening.
Yeah. Shall we start introducing this presentation, sir, Natarajan sir?
Yes, sir. Yes, sir. Yes, sir. And
Yeah.
good evening, all. This is the third week from Tiruvallur Medical College. We are conducting this program, and my postgraduate Javad will be presenting a CVS case today. And first of all, I thank Dr. Palneppan sir and Dr. Saravanan sir, who is Saravanan sir is HOD of Medicine and PhD College, who is coordinating this event. Thank you, sir. And I thank Dr. Aravind Kumar sir, who has joined from Kaveri Hospital. He is a chief interventional cardiologist. Thank you very much, sir, for coming to this program. And I also thank my colleague and Professor Dr. Chakravarti sir in Tiruvallur Medical College for attending and sharing his knowledge in this program. We're going to share. And anyway, shall we start the presentation, sir? My postgraduate, shall we start, sir?
Yes, sir. Please proceed, sir. Please proceed. Sir.
Javad, you can start the presentation, Javad. Go slow and clarity. With clarity, you have to present it, okay?
Okay, sir. Thank you, sir. A 60 years old male patient named XYZ, resident of Tiruvallur, farmer by occupation, came to hospital with chief complaints of breathlessness for the past 12 months, palpitations for 3 months, easy fatigability for 12 months. The patient was apparently normal 12 months ago when he started developing breathlessness and climbing 3 flights of stairs. This is NIHA class 2. It was insidious in onset, gradually progressed to breathlessness, even at rest for the past 10 days. NIHA class 4. Breathlessness was increased on lying down since past 10 days, which was relieved on upright posture. There is no history of symptoms suggestive of paroxysmal nocturnal dyspnea, not associated with wheeze, no history of seasonal variation of breathing difficulty. Sir, can I proceed, sir?
Yes, yes. Go slow with clarity in your presentation. Okay.
Patient also experienced palpitations, which is like fast and irregular beats since past 3 months, insidious on onset, progressive, aggravated on exertion, relieving on taking rest, associated with giddiness on and off for past 1 month. It's not associated with sweating, nausea and vomiting, not associated with chest pain, not associated with cold, cough or fever. Patient also complaints of easy fatigability for past 12 months.
Javad,
Patient
it is
was
not
apparently
clear.
normal 12
It is
months
not
ago
clear.
when he developed easy fatigability of insidious in onset. Sir, hello?
Your connectivity is very poor, I think. So it is coming intermittently, Javad.
Sir,
Just
okay.
go slow, steady. Okay.
Okay.
Javad,
Sir, now
go to the previous slide.
Yes, sir. So now it's okay, sir. Voice is okay. Sir.
Yes.
Okay.
Yes. It's okay. So your the prime complaint is breathlessness, isn't it?
Yes, sir.
Class V NYHA class.
Yes, sir.
What is NYHA?
The New York Heart Association, sir.
Is it restricted to breathlessness or something else can also be
Sir,
classified on the basis of IHA?
It's also can be used for angina, palpitations, fatigueness. Only in patients of cardiac patients, sir. Only in cardiac patients.
So you told, sir, Nara sir, can we ask in the history itself questions?
Yes, sir. Yes, sir. You can ask, sir. For everything, you have to ask so that he can just give a clarity on it. Okay.
So what is meant by NYHA class 2, Jawad?
Sir,
In other words, you tell me about the NYHA class 1, class 2, class 3 in simple terms.
sir, NIH class is used in cardiac heart patients, which is classified into class 1, class 2, class 3, class 4, which is mild, moderate, moderately severe, and severe, sir. In class 1, there is no limitation of physical activity. In class 2, there is slight limitation of physical activity. In class 3, there is marked limitation of physical activity on strenuous on routine works. And there is class 4, even though patient is at rest, he finds it very difficult. There is dyspnea on
He will not be
responses.
able to do any work without any discomfort, isn't it?
Yes, yes, sir. Yes, sir.
So, classify in detail about NYHA class. That is slight limitation of activity. Whether ordinary activity will create problem or extraordinary activity will create problem. Climbing
Sir,
three flights of stairs, isn't it?
in
This is
class
the,
2, the patient. Yes, sir.
I'm asking you, climbing
Yes, sir.
3 flights of stairs for the patient in the 60s. This is an ordinary activity or extraordinary activity.
Sir, it's extraordinary activity, sir.
So, breathlessness and extraordinary activity will come under which class? Which
Sir,
class
class
1
2,
or class 2?
class 2, sir.
Then what is class 1?
So there is no limitation of activity, sir. Physical activity, sir. Ordinary activity doesn't cause any.
Do you think then we are in NYHA class 1?
Yes, sir. Patient only of cardiac diseases only can be classified under NIHA class, sir. NYHA, sir. Or very risk factors such as hypertension.
That comes under something, you are telling the cardiac failure classification. Diabetes, hypertension, everything comes under class 1. Isn't it?
Yes, sir.
So,
Yes, sir.
what is class 1?
So, in class 1 is actually no limitation of physical activities, sir. Ordinary activity doesn't cause any symptoms such as palpitations, fatigue. There is no shortness of breath.
Do you think a
But
person
there is,
in 60s will climb 3 flights of stairs without any difficulty? That too with the heart disease. Any person in the 60s will have breathlessness and climbing the 3 flights of stairs. So that would be coming under the class 1. Sir, Nata
okay,
sir,
sir.
what you are saying, sir? Nata sir? Okay, then it was insidious in concept, it gradually progressed to breathlessness even at rest for the past 10 days. That is NYHA class 4. That comes,
Yes, sir.
that is, so breathlessness increased on lying down since 10 days, which was
Yes, sir.
relieved on upright position. So that
Yes,
is,
sir.
that is defined as
Orthopnea, sir.
orthopnea. What is PND?
PND is when patient lie down and they went for sleep after 2 to 3 hours of sleep, patient finds breathlessness and he will be relieved with a recumbent position, sir. It causes because in nighttime sleep, REM there is REM sleep, sir, which causes a decrease in sympathetic activity, which causes and there is a pooling of blood. There is increased venous return to the heart, sir. Already failing heart can't able to pump the increased input, sir. So the patient finds difficulty in the night time, sir, especially during REM sleep, sir.
Okay, okay, go ahead. And the next slide, go to the next slide.
Thank you, sir. Patient also
Next slide,
experienced palpitation. Yes, sir.
palpitations. Okay.
Yes, sir. Palpitations in the form of fast and
Define
irregular beats.
palpitations. Define palpitations.
Sir, it is uncomfortable sensation of own heartbeat, sir, in the form of rate, rhythm, and contraction, sir. Abnormal contraction, sir.
Force of contact. That is,
Force
it
of,
is used
yes,
to
sir.
variations in rate, rhythm, and force of contact.
Force of contractions.
You have written it as a fast and irregular. So you have touched upon rate and rhythm, isn't it? rate and rhythm, isn't it? Jawad?
Sir, sorry, sir.
Fast and irregular means, so the rate is fast and the rhythm is irregular.
Yes, sir. Fast rate
Like
and
that.
irregular.
So that implies okay. Then aggravated on exertion, relieved on taking rest. So associated with giddiness. This giddiness comes on and off, isn't it?
Yes, sir. Patient complaints of giddiness, sir. On and off.
Whether is it associated with syncope?
Patient doesn't complain of syncope, sir, but he complains of giddiness, sir. Syncope,
Okay.
there is a lots of consciousness, sir. Sir, okay, thank you, sir. Can I continue, sir?
Yes.
Palpitation is not associated. Yes, sir.
Excellent. That also that ROP told.
Yes, sir. Can I continue, sir?
Yes.
Sir, thank you, sir. Easy fatiguability for the past 12 months. Patient was apparently normal 12 months ago when he developed a easy fatiguability of insidious onset and gradually progressive. Initially, he could do manual work in the field throughout the day, but currently becomes fatigued after walking 100 to 200 meters, sir. It was associated with exertional dyspnea and palpitations. There's no history of chest pain, syncope, fever, weight loss, or bleeding manifestations, sir.
Okay.
There's no history of pedal edema, abdominal pain, dyspepsia, right hypochondrial pain, puffiness of face. There's no history of involuntary movements, skin rashes, joint pains. There's no history of hoarseness of voice, sir.
Yes.
Hoarseness of voice relation in cardiovascular system, Jawad.
Sir, in case of mitral, there is an enlargement of left atrium, sir, which causes compression of left recurrent laryngeal, no? Which can causes hoarseness in case of Wagner syndrome, sir, in the form of Wagner syndrome.
Yes. Yes, okay. Proceed.
Past history of similar complaints in the past.
Stop.
Hello,
Stop.
Dr. Nikhil. Who is that presenting?
Jawad.
Okay.
Jawad, sir. Jawad.
Okay. Okay. You have done a good job. You are presenting well and you are going smoothly. Based on the present history, what do you think the 60-year-old gentleman has?
So, based on the patient complaints of dyspnea, palpitations, and easy fatiguability, most probably the patient might be having valvular heart disease, sir.
Why valvular heart disease at 60 years? What is the commonest age of valvular heart disease in Tamil Nadu?
So, post 70 years.
What is the age of the rheumatic fever patient will be?
Sir, 5 to 15 years.
After, what is the natural history of any valvular heart disease in either it is mitral or aortic, means what is the age group with this? What is the natural history? After how many years of rheumatic fever, the likelihood of the patient having a
Usually 20 to 40 years age, the patient will be having rheumatic valvular disease.
What is the natural history? Means possibly after how many years after the rheumatic fever, the patient has a established heart disease?
So, the 20 to 25 years post rheumatic.
Which is which valve you are saying, mitral stenosis or aortic stenosis?
Sir, my aortic stenosis.
Mitral, which is common, aortic stenosis or mitral stenosis?
Mitral stenosis is common, sir.
Okay, mitral stenosis, what will be the likely age of presentation? See, you are seeing it in the OPD. How many patients you are seeing at 60 years and how many patients you are seeing at 30 years?
More patients, 30 to 40 years. Sir.
Okay, more patients you are seeing at 20, 25, 30. See, the natural history of rheumatic fever is that between 5 to 15 years in the pediatric age group occurs, and after 15 to 20 years, the likelihood it progresses to a established mitral stenosis. So the natural history, if you are asked, means you have to tell this. So it takes 15 to 20 years for the after the rheumatic fever. If at all the patient is destined to the mitral stenosis, it takes 15 to 20 years. For aortic stenosis, it takes another next 1 decade. So it means 25 to 30 years. So most of the patient you are likely to see is between 25 and 40, not at 60. So what is your possible diagnosis at 60 years with presence of dyspnea and exertion, progressing to class 2, from class 2 to class 4 in the last 1 year, and associated
Palpitation.
with irregular palpitation, you are saying, confessing. It means that I assume it is atrial fibrillation. So what is the likely diagnosis? For me, it is not rheumatic heart disease because the age group for valvular heart disease, the age has gone. So what is the likely heart disease?
Degenerative valvular heart disease.
Okay, degenerative valvular. What is the degenerative valvular heart disease you are going to think about in this patient?
So most probably mitral valves.
How many
Because
mitral
patient is
stenosis, mitral degenerative mitral stenosis you have seen, or mitral regurgitation you have seen in this age group? How
so
frequent is the
in this
mitral
age group,
degenerative one?
usually in this age group, I mostly think of aortic stenosis. But because
Then
the
you are
patient is having
you have the diagnosis, you have the history, and you have the interpretation in your mind, and you cannot jump from the diagnosis, right? They see your examiner only will examine the integrity and the integral way of thinking and how do you approach the patient. That's what we want. We don't want the diagnosis per se, because everybody knows that you know the diagnosis. So right, this patient, if at all there is a degenerative valvular disease, mitral stenosis degeneration is not the common disease at 60 years. I accept it is a valvular disease. Aortic stenosis is much more common in this age. So is this patient having a aortic stenosis or something else by the history?
aortic stenosis.
So what is the common presentation of aortic stenosis?
So the patient comes with either syncope, angina, or dyspnea. Sir.
Okay. Will the patient come with orthopnea and aortic stenosis?
In other words, what is the meaning of orthopnea? When it will happen,
The patient is an heart failure. You can present with orthopnea.
Yes. See, which valvular heart disease, the orthopnea
Left.
is more common, mitral or aortic?
Sir, aortic. Sir.
Yeah, தம்பி
is
என்னப்பா
it
நீங்க
so?
Eh?
Is it so?
But mitral pulmonary hypertension develop ஆயிடுச்சுன்னா name just RV dysfunction எல்லாம் இருக்குல்ல.
Yes, sir. Sorry.
See, you have to certain
Still you
features
have,
are very common. You told exertional dyspnea, exertional angina, and syncope is the presentation for aortic stenosis. Where is orthopnea? If there is orthopnea was present, they would have told orthopnea is also a part of your symptom triology. Yeah.
Yes, sir.
And so it is not happening. So it means that orthopnea is not the common unless the patient has got a associated mitral disease or the patient has gone into LV dysfunction. Right? So
Okay, sir.
from the history, again, I am not convinced about their diagnosis and discussion. So it is not rheumatic heart disease because natural history doesn't permit you to say rheumatic heart disease, but it's not the age for rheumatic heart disease. Even though the patient can have rheumatic heart, but the natural history is not favorable to say it is rheumatic heart disease. Then what else? What other disease you are told? The degenerative aortic stenosis. Fine, possible provided the patient has got a LV dysfunction, severe aortic stenosis with LV dysfunction and atrial fibrillation and has got a orthopnea. Fine. What other disease you think about in this patient?
This is coronary artery disease and
Excellent. What is common? See, 60 years in this patient, a silent ischemia, even though I do not know whether it's diabetic or not, a silent ischemia could be there and could have caused a insignificant LV dysfunction, which might have precipitated dyspnea and exertion, orthopnea, atrial fibrillation, everything might be there. Angina liquidum might be there. Right. What other disease you think of?
Other diseases are cardiomyopathy. If the patient is alcoholic, there will be dilated.
Well, I'm not
cardiomyopathy,
talking about your alcohol history. I'm only talking about the present illness. That's all. See, we have to discuss a lot. Quickly tell me. You have to discuss. Very simple. What are the diseases? Yeah, diabetic might be there. Diabetic can have a diabetic cardiomyopathy. Hypertension might be there. Hypertensive heart disease. See, this is the age group with which all the risk factors comes into play, and coronary disease all are common. And for me, the rheumatic mitral stenosis or aortic stenosis, even though it may be present in this patient, is not the commonest diagnosis because for a common diagnosis to happen, the natural history should come into play. Beyond the 5th decade or 6th decade, you have to look for the associated coronary disease, diabetic related disease, and hypertensive disease should also come into play. And a degenerative aortic stenosis is there, but the orthopnea is not the commonest symptom. It is some other symptom like exertional angina, exertional dyspnea, and exertional syncope is the common symptom with which it can happen. Right? So
Yes,
you have to discuss with the given history.
Okay, sir.
Do not harbinge on the diagnosis which you know, which might be an abnormal presentation. So you do not go to a diagnosis straight away. You just discuss what is there in the given patient, right?
Yes, sir.
Please proceed.
One more
Thanks.
thing, Jawad. What
Sir.
important history? Sir has told that Sir has thought from the other side. So still, if you are thinking of rheumatic fever, one more important history, rheumatic heart disease, you didn't tell. What is this? In case you are going more in favor of a mitral valve disease, one more symptom you didn't mention in the history. What is the history? Which you didn't tell.
Sir,
Hemoptysis you didn't tell.
yes, sir. Yes, sir.
Isn't it? So what are the causes for hemoptysis in a cardiovascular system? That is an
Most probably
important symptom.
Yes, sir. Yes, sir. Patient might be because of MS. Patient might be having a increased pulmonary hypertension. That causes.
I'm asking. Pathogenesis after that. What are the causes for hemoptysis in a case of cardiovascular system? I'm asking as a whole.
Sir, mitral stenosis.
Okay.
There might be in pulmonary hypertension also it can causes, and then
Okay.
pulmonary embolism in patients of pulmonary embolism.
Pulmonary embolism. Okay. Then
And in infections
the patient has irregular fast heart rate.
Sorry, patient will AF aortic atrial fibrillation taking on drugs, sir.
Oh, okay. Now tell me the reasons for pathogenesis for hemoptysis in a case of mitral stenosis.
Mitral stenosis, there will be pulmonary hypertension, sir, which causes
bronchial. Yes, tell me.
Sir, because of pulmonary venous hypertension, there will be a rupture of bronchial veins, sir. Which can patient can present with hemoptysis.
Okay. Then other reasons for hemoptysis in MS.
In fact, in pulmonary edema, patient may be present in pulmonary edema, which can
cause pink
frothy sputum, sir.
Then winter bronchitis. Winter bronchitis can be a cause for
okay, sir.
hemoptysis in the mitral stenosis. Go ahead.
Okay,
Go ahead to the past history.
Okay, sir. Sir, can I go with the past history, sir?
Yes, past history. Yes.
Sir, history of similar complaints in the past. History of some heart disease in the on patient was on irregular treatment. No records were available. Patient was not a known case of hypertension, diabetes, chronic kidney disease, asthma or old PTV, pulmonary tuberculosis. There is no history of chronic fever. There is no history of any cardiac surgery in the history. There is no history of drug abuse. Sir, can I go with personal history?
No. In the past history also,
Patient
you have to tell one more. No. In the past history also, you have to tell one more important point.
Okay, sir.
Which is a negative history, which helps you in finding out the etiology.
Patient
you ask for that. You ask for the history.
Sir, throat infection.
That is the lifeline of rheumatic heart disease. That is true. What is the history you will ask?
previous infection.
No, your line is not clear. Michelle, Jawad, Jawad.
Sorry, sir.
Yes. Tell me
Hello?
the history, importance.
Sir,
You have
there is
written
any
history
history of skin
hmm.
rash,
You have
joint
written
pain?
no history of, yes. Where is the joint pain?
Sir, previous in negative history I have written. Sorry, sir.
In the past history, that has to be written in the past history, na? Patient in the 60s, you have written, you are not mentioned in the past history. During childhood, any history, you have written everything, involuntary moments, everything, isn't it? Then go ahead. You have to tell the past history of fever with recurrent, history of recurrent fever with joint pains to rule out rheumatic heart disease. Because multiple heart disease still rheumatic fever is the first cause.
Okay, sir. Okay, sir. There's
Okay.
okay, sir.
Recurrent
There's no
history of
history.
fever.
Okay, sir.
Yes.
There's no history
Next.
of
Go
chronic
ahead.
fever with
Go ahead. Go ahead. Go ahead with the
Okay.
personal.
Thank you, sir. Personal history: patient takes mixed diet. Bowel and bladder habits are normal. Sleep and appetite was normal. Patient was occasionally alcoholic, not smoker. Socioeconomic status according to modified Kuppuswamy scale, lower class, sir. Family history: there's no significant family history. No history of sudden deaths in family. Not a consanguineous marriage, sir.
What is socioeconomic Kuppuswamy grading?
Sir,
Kuppuswamy
modified Kuppuswamy.
socioeconomic status. Yes. Modified Kuppuswamy grading.
Sir, it takes into account of three factors, sir. Patient, whether patient is educated, how much patient is educated, education of the
No,
family head.
we are worried about the overcrowding. What is, in other words, overcrowding cities, which disease?
Sir, in the lower class, patient is more prone for infections, sir. There is a crowdness present.
I'm asking about overcrowding only.
Yes, sir, overcrowding, sir.
Overcrowding.
There is present of
Military, in military dormitories
yes, sir.
or some in prisons, that would be overcrowding. So what is this smoke? Or hostels? What is
Yes, sir.
this? You are worried about the equality only.
Yes, sir. Yes, sir. This
So
there is
define overcrowding.
yes, sir, overcrowding, sir.
Define overcrowding.
Okay, sir.
Define overcrowding.
Sir, define, sir, number of persons. There's more than five persons and 5 adults in the rooms, sir. Not dividing, not sharing the rooms.
You have to tell about that. And 2 persons of
Actually,
more than
according to
opposite sex.
sir, one room 2 persons should be there, sir. Commonly, in one room there will be 2 persons. In 2 rooms there will be 3 persons.
Yes. You have to mention about the square feet also.
Okay, sir.
In 70 square feet room, 2 persons are occupying means then it's overcrowding. Then
Okay, sir.
These are all social history. These socioeconomic status history. We are worried about the increased prevalence of rheumatic heart disease because of the overcrowding. So
Okay, sir.
that comes. You have to take it as a point. Next slide.
Okay. A 60 years old male, known case of heart disease, not on treatment, presented with complaints of dyspnea, irregular palpitations, easy fatigability, suggestive of left heart failure features, and probable atrial fibrillation. My differential diagnosis will my involvement will be most probably like valvular heart disease or dilated cardiomyopathy, sir.
Javad, the commonest thing in this age group, without examination, based on the history, the complaints of breathlessness, palpitations, easy fatigability. You have to think of the commonest problem is heart failure. 60
Okay.
years, any coronary heart disease, any aggravating factors like anemia. That is the most commonest thing we have to think of. Okay.
Okay.
Directly, you cannot go to say it is a dilated cardiomyopathy. Directly, you cannot go and say it is a valvular heart disease. Until otherwise, you go for examination and prove it. Based on the simple history, without knowing any previous past history, what is the exact treatment he has taken. The most common thing to be presented as Arvind Masar asked was is a heart failure. That is the
Yes,
most
sir.
common thing you have to think of. Okay. Now we
Okay,
have to
sir.
go for examination and prove what is the thing. So go for examination.
Thank you, sir. Patient was conscious, oriented, cooperative. Weight of the patient was 74 kgs. Height 175 centimeters. BMI of the patient was 24.44 kgs per meter square. No pallor, no icterus, no clubbing, no cyanosis, no pedal edema, no generalized lymphadenopathy. General examination. Oral hygiene, there is no dental caries, no markers of congenital heart disease, no markers of infective endocarditis, no markers of ischemic heart disease, no markers of atherosclerosis, HIV or TB. There is no peripheral signs of aortic regurgitation.
Name some markers for congenital heart disease.
Patient, there is a recurrent infections, history of recurrent infections in the prenatal.
See, markers, we are speaking about markers, not about the symptoms. You are saying there is no external markers suggestive of any congenital heart disease. So name some congenital heart disease. What is the commonest external markers you are going to examine so that you have to suspect that congenital heart disease internally? That is mean by markers. Name some congenital, that is external markers.
Low neck, low,
Low hairline.
down-
Low hairline.
low hairline, hypertelorism. There is a coloboma in the eyeball, coloboma. Absent radius, palmar piece.
See, while presenting, what you have to do is, Jawad, these are the markers. If I see these markers, I will suspect internally either ASD or VSD or any PDA or any other pulmonary stenosis. Like that, you have to go for. That is the congenital, that is marker which suggests you have a congenital heart disease internally. So you have to put it, what are the external markers? What will you suspect internally based on the findings? So that's what we expect. You try to
Turner
say any two
syndrome.
or...
Turner
okay.
syndrome, we will suspect a coarctation of aorta. There is a webbed neck, there is a neck webbed neck. And there is in Marfan syndrome, we can suspect of any aortic root diseases, such as aortic dilatation and all. There will be
What are
like
the markers?
tall, sir.
Actodactyly, tell.
Tall habitus, sir. The patient will be having a supravalvular aortic stenosis in case of Williams syndrome, sir.
What are the markers? External markers.
Elfine faces, sir.
Williams syndrome. Pardon?
Elfine faces, sir. Faces, sir.
Oh, okay. Don't complicate too much because then the next question will come. How do you classify elfine cases?
Okay, sir.
So tell simple terms. What will be the associated morphology with Porter syndrome? Morphology. External appearance. Porter syndrome.
Porter syndrome. There will be absent radius. Associated ASD.
Associated ASD. Okay. What are the manifestations, external manifestations of Down syndrome?
So there is a epicanthal folds. Patient will be having a open mouth, sir, protruding of tongue, and there will be upslanting of palpable features. Simian crease will be present in the palm, sir.
Then, what is clinodactyly? Clinodactyly.
Fifth finger will be
The phalanx, the fifth finger would be sharp. This is
Short,
it.
sir. Yes, sir.
Then
Fifth
what
finger
is sandal gap?
This saddle. There is a gap between first grade toe and other grade toes, other toes, sir.
What are the cardiac manifestations of Down syndrome?
Most probably ASD, VSD.
Is it ASD or VSD or something else?
Cushion defects, sir.
Atrioventricular cushion defects.
Cushion defects.
Then premature occurrence of pulmonary vascular disease.
Yes, sir.
What are the markers of ischemic heart disease? Or markers of atherosclerosis? Both go together only. What are the external markers of atherosclerosis?
There will be regarding to faces. There will be faces and the eyes. There will be xanthoma.
Then there will be earlobe crease,
Yes, sir.
palmar hyperkeratosis, palmar hyperkeratosis.
Yes, sir.
Then
Xanthomas are
xanthoma. You want to be specific more?
Okay, sir.
Xanthoma or something else? That sounds like xanthoma.
Xanthelasma and xanthomas.
Xanthelasma.
There will be in eyes, so we can see arcus senilis.
Arcus senilis. Okay.
Sir.
What are the cardiac manifestations of HIV? HIV, if you read HIV, then half of the medicine is done. What are the cardiac manifestations of HIV?
Increased incidence of this premature incidence of CADs.
Okay, very good.
There's a increased chances of infective endocarditis, sir. There is more infection. There is more chance of infective endocarditis. There will be chances of arrhythmias. Sir. Secondary to drugs.
Three layers of the heart, which should be afflicted with HIV. Pericardial effusion.
Pericarditis. Okay, sir. Pericardial effusion, sir. The form pericardial effusion. Kaposi sarcoma tumor will be.
What is the relation of Kaposi sarcoma with the cardiovascular system?
Sorry, sir.
Go ahead. Vitals.
Yes, sir. Patient pulse, sir. Pulse was 87 beats per minute. Irregular rhythm with variable volume, no specific character, felt in all peripheral pulses, no radioradial or radiofemoral delay, condition of vessel wall was normal, pulse deficit, there is a pulse deficit, sir. Heart rate was 104 beats per minute, pulse rate was 87 beats per minute with a deficit of 17 beats.
Yes.
Blood pressure, sir. Blood pressure was measured in supine position. With right upper limb, BP was blood pressure was 100/80 millimeters of mercury. Left upper limb 100.
So what is the pulse pressure here? Note. So we have to keep in mind. What is the pulse pressure here?
20 millimeters of mercury, sir.
20 to 30. That is 30 in the lower limb and 20 in the upper limb. Go ahead.
20 to 30 seconds.
What do you conclude after your pulse and BP?
So there is a
narrow pulse. Narrow
you
pulse
have to
pressure.
tell another diagnosis. One more step in coming to your conclusions. That will help.
You got an irregular pulse and
like
narrow pulse pressure. What will be it may not be correct, but what will be a probable diagnosis here?
Most probably with actually in this age group we'll thought of a high BP, sir, systolic BP, but the patient will be is having 100/80 mmHg. So most probably the patient might be having aortic stenosis, sir, associated aortic stenosis, sir, with low pulse pressure.
What is the importance of pulse pressure with alveolar heart disease?
Sir, normal pulse pressure is 30 to 60 mmHg, sir. In whether the patient in a regurgitating lesions and all, there will be widened pulse pressure, sir. Normally, in the stenotic lesions, in aortic stenosis and all, there will be narrow pulse pressure, sir.
So what will happen in this dilated cardiomyopathy or cardiac failure to the pulse pressure? What will be the BP like?
Sir, dilated cardiomyopathy.
You have seen many more and more number of cases of DCM getting admitted in AER.
Yes,
So
sir,
what
there
is
is
it
a
like?
sir, there is a narrow, sir, low volume, sir, low volume pulse. BP will be low.
Sometimes it will be around 100 per E, isn't it?
Yes,
You
sir,
will not
weak
get
pulse.
the weak pulse and narrow pulse pressure. So there are
Yes, sir,
chances for failure also.
yes, sir.
Here, go ahead.
Temperature 98 degrees, 98.2 degrees Fahrenheit. Saturation was 97% under room air, sir. JVP appears to be elevated, sir.
What wave was
What
that?
is it? What wave?
In the measured JVP was measured, sir, which shows a
See,
9. Sir,
if you say
Nine.
Shows
JVP
it is
elevated, you should
elevated.
say what is the wave that is getting elevated.
right side heart failure, there is increased.
What is the wave? What wave did you see in the JVP?
Sir, patient patient was asked to supine to ask
I
to leave.
understand. How did you? I am not asking question. How
See.
did you see it? What wave did you see it? What are the waves in
A
JVP?
wave, C wave, V wave.
What are the positive and what are negative waves?
Sir, there are like 3 waves, sir. A, C, V are positive waves, sir. With the X and
Okay.
Y waves are negative waves, sir.
Okay. What is the positive? Elevated means you are mentioning about the positive wave. What is the
Yes, sir.
positive wave you saw there? And how did you say conclude that it is elevated?
Javad, you say the patient has a palpitation, so he is having an atrial fibrillation. Then what wave will not be seen actually?
A wave, sir.
Then what is the positive wave which is maximum seen there?
C wave, sir.
Hey, V wave.
Sir, V wave, sir. V wave.
In other words, we will come to the what are the implications of C wave? What is the pathogenesis for C wave? If you get caught, then the questions will go towards the mistake we committed. What is the reason behind C wave?
Sir, when there is a
There are two reasons.
ventricle tries to contract, there is a bulge in the tricuspid wall, sir. Tricuspid wall bulge will be the same, sir. Because of the C wave, sir.
Okay. Then other reason? Other reason?
Another reason for C wave. Another V wave, sir.
C wave. That is a C wave maybe associated carotid pulse will push the wave. That is the other reason.
Okay.
Associated carotid pulse.
Okay,
So
sir.
what would be the normal predominant wave you will see? That is theoretical purpose I am asking. Of the 5 waves, which one will be the predominant wave? J wave, or V wave, or C wave, or X or Y distance?
Sorry, sir.
Which way would usually in a normal patient, which way would you will see? In a normal person.
A wave.
You refer. Okay. Go ahead.
No, thanks. Inspection. I proceeded with the CVS examination, sir. On inspection, chest wall was elliptical and symmetrical. No kyphoscoliosis, no pectus excavatum of carinatum. Tracheal position appears to be in midline. Apical impulse pi fifth left intercostal space lateral to midclavicular line. Left parasternal pulsation present. No epigastric pulsations. No supraclavicular, infraclavicular or suprasternal pulsations. No precordial bulge, dilated veins or surgical scars or any sinuses.
So what is your take on apical impulse?
Is displaced laterally, sir. Usually it's 2.5 centimeters medial to midclavicular line, sir.
Okay.
Is it 2.5 centimeter medial to the midclavicular line?
1.5 to 2.5 centimeters.
What is the normal apical impulse position?
Sir?
Where is the normal apical impulse located?
Sir, left fifth intercostal says, sir, medial to midclavicular line, sir.
Medial to the midclavicular, just medial to the midclavicular line. If we are saying 2.8 centimeter, it comes around 1 inch. That would be
Sir, okay, sir.
the half would be narrow. So it is a
Okay,
half centimeter, half inch internal to the midclavicular line. So here it is shifted just out only, isn't it?
Yes, sir. Yes, sir. Yes.
So the apical impulse is displaced laterally.
Yes, sir. Laterally, sir.
What is the reason for displaced laterally in this patient?
Because of ventricular.
See, when the apical impulse is normal, what valvular heart disease you are likely to think of?
Mitral, sir.
Mitral?
Mitral stenosis, sir.
Okay. When the apical impulse is shifted down and out, what will you think of?
Aortic regurgitation, sir.
Very good. When the apical impulse is shifted just laterally means what will you think of?
MS mitral. Yes, aortic stenosis, sir.
Aortic stenosis is a inward, concentric LVH is a inward enlargement, not a hypertrophy, not an enlargement. See, when there is
Okay,
only
sir.
dilatation, you feel you will have a apical impulse, movement of apical impulse down and out or anything. When there is hypertrophy, means it is only inwardly moving hypertrophy and it is not going to expand unless it's a failure, right? Aortic stenosis will not displace the apical impulse, it is only heaving apical impulse in the same place. Whereas mitral stenosis will have a tapping apical impulse in the same place.
Okay, sir.
Here, mitral aortic regurgitation will have a down and out. Mitral regurgitation is a volume overload. That will be the apical impulse.
Mitral regurgitation will be
See,
down
in
and
simple
out, sir.
words, your left ventricle and hypertrophy will not move the apical impulse anywhere. So aortic stenosis will remain the same. Left ventricular underfilling due to mitral stenosis also will not move the apical impulse. It is a tapping apical impulse, rapid filling, and the first thought sound will give you a tapping apical impulse and remain the same because it's the underfilling of the left ventricle. When the left ventricle is volume overloaded, either because of a aortic regurgitation, which is the commonest prototype, it's a shifted down and out. Mitral regurgitation, the volume between the left ventricle and left atrium is not very much compared to the left ventricle and aorta. The apical will not be displaced very much lower down and out, but there will be some displacement downward and slightly some displacement laterally, and it will not be amounting to aortic regurgitation. At the same time, it is not in the normal position, where it is apical impulse is slightly hyperdynamic, not hyperdynamic as compared to aortic regurgitation. But what is the reason for lateral displacement? What you are doing? Fifth intercostal space, lateral to midclavicular line. What is the reason? You are given it.
This is an inspection. Do you want it to confirm the palpation?
Sir.
Do you want to confirm the position with the palpation?
Aye, sir.
Okay, you can confirm with palpation. Confirm with palpation.
Yes, sir. Sir, tracheal position was confirmed, sir. Apical impulse felt in the left fifth intercostal space, 1 centimeter lateral to midclavicular line, sir. There's a grade 3 parasternal heave, sir. Epigastric pulsation not felt.
Still, you are saying it's lateral only, not down. It's still in the fifth intercostal space only, isn't it?
Yes, sir. Yes, sir.
Okay, good.
Is it a RV apical impulse or left ventricular apical impulse?
Left ventricle.
See, when the left ventricle apical impulse means 1 centimeter lateral to midclavicular line cannot happen with the left ventricular impulse. And especially you have mentioned is tapping.
Yes, sir.
The tapping only says the left ventricle is being underfilled by the tight mitral stenosis, right? So
Yes,
when
sir.
the left ventricle is underfilled, means left ventricle impulse will never move outward, downward, laterally. Nothing will happen, right?
Yes,
So
sir.
you are giving a clue there. Parasternal heave is there, no? So
Yes,
what
sir.
does parasternal heave tell you?
Patient is having a right ventricular failure, or the patient is might be having pulmonary hypertension, pulmonary artery hypertension.
See,
Either two reasons would be there. Parasternal heave. What are the reasons?
Right ventricular enlargement or right ventricular failure,
Or
or secondary pulmonary hypertension.
right? See, here it's the clue is there. When there is a parasternal heave, it pushes
sir.
the see, like a boot shape carved in the top. So it
Yes, sir.
pushes the ventricle impulse laterally. So it
Okay,
means
sir.
that the whole parasternal heave is a continuum into the apical impulse.
Okay,
Right?
sir.
It is the right ventricle apex. Here the diagnosis is very clear, crystal clear. It's the right ventricle apex. Parasternal heave is there, which is continuous and it displaces the apical impulse laterally. It's the right ventricle pressures are much higher. So that's the reason why apical impulse is shifted lateral. Right?
Yes, sir.
so what is the reason behind the other reason behind parasternal heave? It can either be right ventricular enlargement
Or pulmonary hypertension, sir.
pulmonary hypertension. You have already mentioned. I am asking
Any lung infection, we can tell called
when
pulmonary.
left atrium, if the left atrium gets enlarged, do you get parasternal heave?
Left atrium, yes, sir. Backward pressures can cause right ventricle failure, sir. Left atrial dilatation.
Go ahead. So you are telling that the apical impulse is tapping, isn't it?
Sir, sorry, sir.
You are telling it as tapping. The character of apical impulse is tapping.
Yes, sir.
Tapping in that.
Yes, sir. Yes, sir.
So tapping means what would be the location? Where would be the location?
Sir, tapping fifth intercostal.
Will it be in the normal position or it would be shifted around?
It's a normal position.
Okay. So these are the points you are contradicting yourselves.
Okay.
These are the places where you will be caught in the exam. So go ahead. Okay. Last electric is there. Go ahead.
Nice, sir. This palpable P2, sir.
Okay.
Percussion. Right heart border corresponds to right lateral border of sternum, sir. Left heart border corresponds to apex. Liver dullness is felt in the left fifth intercostal space, sir.
What does that mean? Is it needed that line? Liver dullness is felt in the left fifth intercostal. What is the reason?
Sir, there's no pleural effusion associated.
What pleural effusion is it? Does it have a role in cardiovascular system? What is the reason for liver dullness? I don't think it is.
In case of failure patients, we can there will be pulmonedema.
You are insinuating unwarranted problems. Okay, go ahead.
Right heart border corresponds to right lateral border of sternum. Right? So
Yes,
you are saying the patient has got precardial pulsation, parasternal heave is there, and you are having a JVP elevated, palpable P2. It means that the pulmonary hypertension is there. Do you think the right atrium is not enlarged or not enlarged?
Enlarged.
So right atrium enlargement, where you are seeing an X-ray. Time and again you will see an X-ray of vital heart disease. So when the right atrium, the right atrial enlargement is seen beyond the sternum, or how will you define a right atrial enlargement in the X-ray?
Double aorta.
See, double left atrium.
Shadow within shadow is left atrium.
Okay.
the right atrial enlargement, whether it is crossing the midline, okay, straight border of the sternum, or it is
Yes, sir.
within the sternum.
Crossing the midline, sir.
It should be at least it occupies more than 3 intercostal spaces, more than 2.5 centimeters from the midline. Then only you call it as right atrial enlargement by X-ray. See here,
Yes, sir.
you are saying that right heart border corresponds right lateral border of the sternum. Does that mean that right atrium is not enlarged? See, நீங்க வந்து இதெல்லாம் percussion பண்ணிருக்கவே மாட்டப்பா, but you should not commit it as. See, theoretically, by X-ray you are seeing it well away from the sternum, means it is also the, okay, by percussion also it should be well away from the sternum. It entered the right side of the heart, yeah. So then you have
Yes, sir.
to think about and talk. You see, but theoretically you will never know. Nobody does percussion now. So only thing you should do, correlate with the clinical finding and present, right?
Okay, sir. Thanks.
Javad, நீ எதுனாலும் percussion is not important in cardiovascular system. As well as whatever finding you want to say, substantiate it, and if you want to put a percussion, அதுக்கேத்த மாதிரி சொல்லு. Just don't go beyond what is given in textbook and just get caught. Okay. It is not at all needed. Go to the next slide.
Auscultation, sir. Mitral area, start with mitral area. S1 is variable. S2 sound, second heart sound was normal. First heart sound was variable. A low pitched rough rumbling, mid-diastolic murmur of grade 4, heard with the bell of stethoscope, preceded by an opening snap, best heard in the left lateral position with breath held in expiration. Intensity of murmur increases with squatting and exercise and hand grips. Third and fourth heart sounds are not heard, sir.
With the variable S1, how frequently you will be hearing your opening snap? Was there a pre-systolic accentuation was there?
Yes, sir. No, sir. There's no pre-systolic attenuation.
Okay. How about the opening snap?
Opening snap was there's a narrow gap between the S2 and the opening snap, sir. Decreased gap.
Okay. See, you mentioned specifically S1 is variable. So it means that
Yes,
opening snap also they related to the same thing, same phenomenon. Yeah.
Yes, sir. Yes, sir.
When you are hearing a closing sound, variable closing sound means the opening sound also should be variable.
Yes, sir.
See, simple that. See, S1 is closing a mitral valve means the same thing opening also should be variable. Yeah.
Yes, sir. Yes, sir.
See, the simple, you logically think that's all. Opening snap may not be heard in atrial fibrillation. See, you have to be very clear. Opening is the same phenomenon. One is opening and one is closing. That's all.
Yes,
right.
Sir.
So how do you grade? Who graded the murmurs?
Sir, Levine and Freeman, sir.
So how many grades are diastolic murmurs?
Systolic, there are 6 grades, sir. In diastolic, there will be 4 grades, sir.
So systolic, here they're telling grade 4 means?
Grade 4 means murmur with palpable thrill, sir. Loud murmur with palpable thrill.
You have to mention about the extent of the murmur. Is it a localized murmur or is there? You have to mention about the radiation or conduction. You didn't mention about that. So, did you write anything about it's a localized murmur or radiation like that? Because MDM is the only murmur that is a localized murmur that will be circumscribed to the mitral area alone.
Yes, sir. It's not radiating.
So that you didn't mention. You have to write radiation and conduction. You have to write. Yes.
Sir, okay, sir. Thank you, sir.
Next area of importance. This is the primary area of importance, isn't it? Mitral area. Then go ahead.
Next, nice, sir. Tricuspid area, sir. First and second heart sound were heard. A high pitched soft blowing murmur of grade 3 heard with the diaphragm of the steth conducting to epigastrium, best heard in supine position with a breath held in inspiration, sir.
What is Carvalho's sign?
In patient with severe MS, there will be secondary functional PSM murmur in the tricuspid area, sir. It's known as
I
Carvalho's.
was asking about Carvalho's.
Java.
D. Carvalho's.
I am
What is
asking
the
what is
Carvalho's?
Carvalho's sign?
Intensity of murmur increases in inspiration, sir.
In
Inspiration, sir. Inspiration, sir.
inspiration in which side of the events?
Right side, sir. Right side, sir.
What happens to the left side of the events?
Left side means decreases, sir.
In other words, it will be increased in expiration, isn't it? You have written it in the previous slide. MDM
Yes,
is
sir.
more hard
Expiration.
with the expiration.
Expiration,
What is
sir.
the exception for that? D. Carvalho's sign. Exception.
Sir, pulmonary clicks in pulmonary clicks, there will be clicks, sir.
The rule does not apply over there, isn't it?
Yes, sir.
Okay. Okay. Then go ahead. You finish with the auscultation, then we will go for the questions.
Okay, sir. Pulmonary area, first and second heart sound heard. P2 was loud. An ejection systolic murmur of grade 3 heard with the diaphragm of stethoscope. Best heard in sitting and leaning forward position with breath held in inspiration, sir. There's no added sound.
So here
area.
also you hear a murmur with which increases with the inspiration, ejection systolic murmur. So
Yes, sir.
go to the previous slide. Tricuspid area. So we have to go for each and every murmur. Here you are here, soft blowing. So systolic murmur of grade 3. Is it a mixed systolic murmur or pansystolic murmur in tricuspid area?
Pansystolic, sir.
So holosystolic murmur you are telling. So in tricuspid area, holosystolic murmur. Next slide. Pulmonary area, mixed systolic murmur. That is ejection systolic murmur.
Yes, sir.
Yes.
Then auscultation of aortic area. First heart sound was soft. Second heart sound was heard. There is a harsh, rough ejection systolic murmur. Crescendo or decrescendo type. Grade 4. A late peaking murmur. Best heard in aortic area. Radiating carotid artery, sir. Best heard with the diaphragm of stethoscope, sir.
Radiating to carotid arteries with the same intensity or reduced intensity?
Sir?
Radiating to the carotid arteries with the same intensity or reduced intensity? You have to mention about that also.
Same intensity, sir. Sure.
Here you have done a mistake. You are contradicting your point in the regarding the aortic area. You are contradicting a point with palpation and auscultation. Are you able to find out the mistake? I will give you a chance.
You have put it as grade 4/6. Then will it be thrill be there or not?
Yes, sir. Thrill present.
Sorry, come to your rescue. Okay, go ahead. So you should have put it as 3/6, or
Okay.
you should have mentioned here
Thrill present
in the palpation. You have mentioned about a diastolic zone, isn't it? Okay. In the morning I didn't notice it. Now only I have noticed the mistake. So you have to write in a proper way. You should not contradict your indication.
Okay, sir. Summary, sir. Middle-aged man, male, irregular pulse with variable volume.
Stop here. Oh, regarding the auscultation, inspection questions are asked. Palpation up to palpation questions are asked. So
Yes,
regarding the auscultation, sir, Arvind sir,
after auscultation, what is your possible diagnosis?
Severe MS associated with AS, aortic stenosis.
AS severity?
AS also severe, sir.
Okay. See, now you are telling two severe stenotic lesion, the two valves, which is unlikely because two stenosis cannot, severity cannot be assessed. Because once mitral stenosis severe means, it means that the blood supplying, crossing the mitral valve is going to be difficult, and from there on, the pulmonary left ventricle ejection is not going to be great, and you will always underestimate a stenotic lesion in the aortic valve downstream, which is not there. So 4/6 murmur in presence of severe mitral stenosis is unlikely. It cannot happen. Either you are overestimating aortic stenosis or really overestimating mitral stenosis as well. It is not there. Truly, the mitral stenosis may be lesser than what your estimation. And if there is going to be a severe AS,
actually, I saw that case. There was no thrill. There was not thrill at all in that place.
There is no thrill, sir.
Aortic
There
area.
is no thrill at all.
see, in presence of severe AS, which apical impulse will be dominating? Whether aortic stenosis, the apical impulse will be dominating, or mitral stenosis apical impulse will be dominating?
If both MS and AS present, sir, MS
both
will
MS and AS will be there. If there is presence of severe AS, which will be the apical impulse determined by aortic stenosis or mitral stenosis?
Aortic stenosis, sir.
See, mitral stenosis, the pressures are very, very less negligible. Whereas the aortic stenosis pressures are very, very high. So your pressure will be transmitted in the apical impulses will be the higher pressure chamber, it is being affected. So whenever presence of two valvular lesion means whichever the lesion has the higher gradient, higher stenosis and higher gradient will be reflected in the palpation. So here, if you are saying severe aortic stenosis means the patient will have a heaving apical impulse, not a tapping apical impulse. So as your professor says, that for it is not a 4/6 murmur, it should be less than that. Your examination of your thrill and your murmur is not pointing towards a severe aortic stenosis, possibly a moderate aortic stenosis, and possibly underestimated by a severe AS also, if they have MS also. That we do not know. But clinically, it cannot be more than moderate as per your presentation. That's what I have feeling. And your decrescendo, late peaking, I do not agree with it. And second heart sound in the aortic area, what is the second heart sound in the aortic area?
Sir, there is a second heart sound was present.
See, when there is a second heart sound is heard, aortic stenosis severe means what will happen to the second heart sound?
There is single S2, sir.
See, what will happen to the S2? Is it soft? It will be loud. Only two options: soft or loud. Leave alone.
Soft, sir.
Yeah,
if there is a calcific valve, means it becomes soft. If there is a pliable with a severe stenotic valve, means it is loud.
Loud,
right?
Sir.
See, your professors are asking a leading question towards your answer. Right?
Soft, sir. Soft.
The valve, pliable valve means if the severe stenosis will have a loud S2.
Loud
when
S2,
the valve becomes calcific because of the severity, the sound become soft. Right? So you are not mentioned second heart sound heard, but your description, internal incongruency should not be there. You should always go along with the diagnosis. Your inspection, palpation, auscultation should contribute towards your diagnosis, right?
Okay, sir.
Javad, in an examination of a patient, you should not cook up any findings. What is there in the patient, just put it, clinical examination. Finally, there may be exceptions. But what I said, there was no thrill at all in this patient. You just put it as 4/6. I didn't mention in palpation also.
So we should appreciate Javad sir, because of the 8 TGs, he was the one who came forward to present the case. Javad, go to the tricuspid area. So here you are telling one murmur, high pitched, soft blowing, that's holosystolic murmur you told, isn't it?
Yes.
So what is the differential diagnosis for this holosystolic murmur in the tricuspid area?
Secondary to
that gives some points to your
what
diagnosis.
Murmur? What is it murmur? Just mention it.
Sir, pansystolic murmur, sir.
What murmur?
So what is the differential?
Yeah, okay. What is a lesion? What is a lesion?
There are 3 lesions.
TR, sir. tricuspid regurgitation.
TR. Okay,
Yes, sir.
then
Secondary.
there are 3 members for a holosystolic member in tricuspid area. What are the 3 members? Three reasons. The other member, what are the other reasons for holosystolic member?
Pansystolic murmur
Pansystolic member will occur in TR, then
in MR, sir. MR, sir.
MR. Okay, rendu okay.
No, no.
VSD.
VSD.
Yes.
So how will you differentiate all the 3? I am telling you VSD. A small VSD.
Okay, sir.
A small VSD can come to the age of 60 years. Yes, in case.
No, sir. Engaged patient will be presenting in engaged.
No. Small VSDs they can go in for into decades, 7th, 8th decades. Small VSD.
Okay, sir. Okay, sir.
How will you differentiate VSD murmur from there? So here you are telling what is the murmur here? Is it TR or MR or VSD? Here.
In MR and TR, it varies with respiration, sir.
So here you are telling it as TR, isn't it?
TR increases in its inspiration, sir.
So if
Right,
there
right
is
side.
TR, okay. So we are come to a conclusion. Here it's a TR murmur. Then go to the pulmonary area. Pulmonary area.
Yes, sir.
Here you have written as ESM, which increases with inspiration.
Yes,
Isn't
sir.
it? Here
Yes, sir.
you have mentioned it as grade 3, not 4.
Yes,
Here
sir.
you have written it as grade 3. So what is the etiology of this ESM in pulmonary area? There you told the holosystolic murmur, or the pansystolic murmur. Here you are saying ESM. This is the same ESM which is of AS. These are the places where you will get caught.
Sir, pulmonary hypertension.
So pulmonary hypertension. So in pulmonary hypertension, you will be getting ESM, and that is accepted. There are 8 signs for pulmonary hypertension. Of them, one is ESM. But if the ESM comes, the other 7 signs should have come over there.
Okay, sir.
What is the reason for murmur, Thambi? What is the reason for murmur? Why
Basic. Sir is asking about physiology.
Physiology. What is the reason for murmur?
Sir, if like increased turbulence of the fluid to a
through
abnormal wall or increased flow through normal wall, sir.
See, in pulmonary area, was there an abnormal wall?
No, sir.
Was there an increased flow across the pulmonary wall?
Yes, sir.
Why?
Sir, back pressure, because of back pressure, pulmonary hypertension, there is increased flow through the
pulmonary hypertension is a resistant circuit or a underfilled circuit?
Underfilled, sir.
Like pulmonary hypertension, what does it mean? Pulmonary pressure is
sir,
higher
pulmonary
or lower?
Sir, higher, sir.
So when you have
then
a higher pressure area,
will
you have a high flow or low flow?
High flow, sir.
Hey, how there is a resistance to the flow.
See, from a higher pressure means, but if there is going to be a murmur means there should be a increased flow across a normal valve or a normal flow even across a abnormal valve. Here the valve is normal. It means that the other side is increased flow should happen. Increased flow happens in from a higher pressure to a lower pressure area, then there will be increased flow.
Yes, sir.
Or there is a physiologically something like anemia, there will be an increased flow across all the valves. See here in aortic regurgitation, you will always see a higher pressure from left ventricle to the aorta, means there is a large amount of flow through a normal valve, and half of them is coming back, means that ESM also, short ESM will also be here, and EDM can also be here because higher flow across there.
Okay,
right?
Sir.
Here in pulmonary hypertension, the pulmonary valvular resistance, vascular resistance is higher.
Yes, sir.
From the right ventricle to a higher pulmonary vascular resistance, will there be an increased flow or a lower decreased flow?
Decreased flow, sir. From pulmonary area to pulmonary area to pulmonary
From
bed, sir.
RV
That
to
way,
pulmonary area, the flow would be reduced, isn't it?
yes, sir.
Because
Yes,
it is
sir.
pumping against resistance.
Yes, sir.
See,
Yes, sir.
when there is a reduced flow means you are less likely to hear the murmur in the
Okay, sir.
pulmonary area because of pulmonary hypertension. So what
Okay,
you
sir.
are hearing, it might be a murmur of aortic stenosis, which is there. Probably you mistook as pulmonary valve murmur, thinking that it is increasing on inspiration, everything. But possibly the murmur is not from the pulmonary area, it is from the aortic area. Or the murmur, what you are hearing, a pansystolic or a holistic murmur, what you have heard in the tricuspid area, is heard in a lesser intensity in the pulmonary area. Something like that would be there, not
Okay, sir.
related to the pulmonary hypertension, right?
Yes, sir.
Okay, go ahead with the diagnosis.
So my diagnosis: patient middle-aged male with irregular pulse with a variable volume with apical impulse, fifth intercostal left intercostal space with a grade 3 left parasternal heave with a S1 variable in mitral area, PT loud in pulmonary area with a mid-diastolic murmur with a opening snap associated with a diastolic thrill in the mitral area with a systolic murmur in the tricuspid area, grade 3, and ejection systolic murmur in the pulmonary area, grade 3, sir.
You can strike out the last 5.
Okay, sir.
Hmm.
Okay, sir. My diagnosis will be acquired valvular heart disease, probably of rheumatic etiology with severe mitral stenosis with associated aortic stenosis. Patient with atrial fibrillation with features suggestive of pulmonary hypertension, not in failure, without signs of infective endocarditis.
Not in failure. We
When
accept it.
elevated JVP, you consider as a failure or not in failure?
And also the orthopnea, sir.
Orthopnea also there.
Sir, patient because of pulmonary hypertension, there will be increased JVP. Secondary to pulmonary.
That is also failure.
Yes.
Orthopnea?
Orthopnea. What are the signs of left heart failure? What are the signs of right heart failure? Tell me, what are the signs of left heart?
Yes, sir. Dyspnea, orthopnea, these are
Signs,
left heart
I am
failure.
asking. Signs.
Right heart failure signs.
Signs.
And ascites, hepatomegaly, tender hepatomegaly, ascites, pedal edema, right heart failure signs. Sir. Left heart signs.
You told JVP elevated. Okay. Left heart failure.
Left heart failure. Left heart failure. Pulmonary edema.
So here you told orthopnea. What about others? Did you hear any preparations? We didn't go for the other system examinations. Did you find?
Yes, sir.
Did you do that? Did you find
No,
any hepatomegaly?
No, sir. No, sir.
Lungs.
Lungs or normal vesicular breath sounds. Bilateral.
So only thing is elevated JVP. JVP elevated means right heart failure. You have to mention passenger failure only. Then you have to tell about the NYHA class also. The diagnosis. NYHA class 4 symptoms.
Okay, sir. Sir. Okay, sir.
So substantiate your findings. Severe mitral stenosis and with associated aortic stenosis, severity Sir was asking, you didn't mention. There are some signs for severe AS and severe MS. Severe MR.
Yes, sir.
Jawad,
Yes, sir.
see, you will hear a systolic murmur in aortic area in this case. I am saying this systolic murmur is not due to aortic stenosis. It should be something else in a severe MS patient. What are the probability you can have for this patient?
Severe MS.
Can severe MS produce a systolic murmur in aortic area?
Yes, sir.
What are the probability?
If a female patient, now we can think of any hyperdynamic conditions. pregnancy, anemia.
See, the main thing is you have to think of aortic stenosis in this case as can be. It is not actually estimated because of low cardiac output.
Yes, sir.
That we are maybe a pseudo. It should be done with the dopamine stress echo to assess the actual
Yes,
thing.
sir.
Okay.
Low flow, low gradient.
Yes. Another
Yes,
thing is what it can be an aortic sclerosis itself, first of all.
yes, sir.
And
Okay, sir.
if there is a mitral reagitation coexisting with an MS, you can have an systolic murmur in aortic area also. And the tricuspid reagitation murmur also can sometimes radiate to aortic. It can mimic an AS in certain cases. So we have to think other things also, not only AS, because there is no thrill in this patient. If thrill is there, definitely you can say. But since as Sar said there is a low cardiac output, actually you cannot get a thrill in this patient. It has to be done with some cardiac catheterization or dobutamine stress echo only. You can exactly find out what is the severity. So you have to think of many things. Okay. And not only that, it could be an along with anemia also. The patient has anemia due to high output also. They can have a functional flow murmur through aortic. So anything can be there. You have to think everything. Okay. But you have to differentiate. Clinically, you have to differentiate.
Yes, sir.
Okay. So you said the prominent symptom is dyspnea. See, in MS, AS, you say both is there. In which lesion there will be dyspnea prominently?
Aortic stenosis.
It is in mitral stenosis. Mitral stenosis, dyspnea will be prominent. Aortic stenosis, what is the commonest symptom they may present with?
Syncope, sir.
Is it syncope?
Angina and syncope. That is the main commonest.
Angina and syncope, sir. Yes, sir.
Yeah, dyspnea, palpitation, everything points towards palpitation is atrial fibrillation, points towards a mitral stenosis only. Pulmonary hypertension developing under the tricuspid region, usually mitral stenosis. Aortic stenosis, it can occur, but in a later stage, it is not. So dyspnea, it is prominently there. Then you have to suspect MS. Angina, syncope, it is prominent. You have to go for AS. And if the patient is having fatigability more than dyspnea, you have to think of pulmonary arterial hypertension because this patient is having PHT also. Okay.
Yes, sir. Okay, sir.
Okay. Proceed.
What does the symptom EC fatigability signifies? EC fatigability. Patient initially can do the work around the clock. Now he is not able to walk for 100 to 200 kilometers and 200 meters. So,
yes, sir.
what is valvular lesion? You will suspect in the case of EC fatigability. And what is how will you call? What does that mean? EC fatigability means that signifies what does EC fatigability? You told that.
Yes, sir. Yes, sir.
Dyspnea can be attributed to MS.
Yes, sir.
Okay.
And regurgitant lesion.
Regurgitant lesions. So is there a chance for regurgitant lesion in this patient?
Yes,
especially in the murmur, systolic murmur. Why can't it be MR?
Yes, sir. There is a possibility, sir. There is a possibility.
When I auscultated, there was a systolic murmur over the mitral area. Leave alone the diastolic murmur. I was not able to pick it up because the heart rate was too rapid at the time. I was not able to pick the diastolic murmur. I was able to hear the systolic murmur only. So,
yes, sir,
is there a chance for mitral regurgitation for this patient?
Yes, sir. There is a chance.
In other words, if you are able to hear a systolic murmur over the mitral area, I am saying it is because of aortic stenosis. Will you accept it? In ejection systolic murmur heard over the mitral area, will you accept it?
Because of it.
Correct. It's correct. But how will you? What is it called? What is it called? Ejection systolic murmur of AS heard in the mitral area.
Galloway phenomenon.
Galloway phenomenon. Selected
sometimes the murmur can be radiate. AS murmur can radiate to mitral area.
Mitral area. So
Topics, sir.
I am
Topics.
saying, how will you refute a regurgitation lesion in this patient based on the findings? EC fatigability points towards a regurgitation lesion. That
Yes,
is a
sir.
point towards the regurgitation lesion.
But
How will
in
you
there's no hyperdynamic
apical
tapping.
impulse? Before that, before that, before that, before inspection palpation, is there any finding that can refute the regurgitation lesion?
Sir, pulse pressure, sir. Wide pulse pressure.
Pulse pressure is narrow. Okay.
Why, sir.
So regurgitation, we can as for the now there is no possibility for regurgitation lesion, isn't it? Can
Yes, sir.
EC fatigability can be a cause for can AS be a cause for EC fatigability? The
Yes, sir.
triad of symptoms in AS is
Sir, syncope, angina, and dyspnea, sir.
dyspnea. EC fatigability can be contributed.
Yes, sir. Yes, sir. It might be a
How?
symptom of
How? That's what your HOD was asking.
easy because of decreased cardiac output.
Yes, that is because of the reduced cardiac output, because of the low flow, low grade gas. There won't be much expected cardiac output, low flow. So the ECG can be contributed because of the low flow, low grade gas.
Okay, sir.
Okay. So the mitral stenosis, which one again coming to back to the same question? Which one is the severe most severe? MS or AS?
Sir, sorry, sir. Which is
MS or AS here?
in this case, sir. MS.
MS. Then AS will not. AS will not be. So can failure can right-sided failure can occur with AS?
Right-sided
Yes.
failure. Yes, sir. Yes.
What is it called? Can occur. It can occur. What is it sign called?
Barhim, sir.
Is it Barnum or something else? Because JVP is elevated. That's why I am asking you.
Yes, sir. There is a because of increased left pressure in. There is a left ventricular failure in the AS, which can cause pulmonary hypertension.
So what is the sign called?
Right ventricle sinus, sir.
Name. It goes with the name. You refer. Yeah.
Okay, sir. Okay, sir.
Okay, next.
Java, this is a case of rheumatic heart disease with two valve involved. Okay, so there are many
Yes,
patients with multivalvular lesions, and among the two valve involved and among the different lesions, which you feel has a worst prognosis and which you feel has a good prognosis? Among there are so many patients you can see with MSAS like this, MSMR, ARAS, or there are MSAR and MRAR. There are so many different combinations, permutation and combination. Among this, which has a best prognosis and which has a worst prognosis?
Worst prognosis will be AS with MR, sir.
AS with?
MR, sir. MR.
Okay, not right, not right. Which has a worst prognosis? It is an MS with AR.
Okay,
Mitral
sir.
stenosis with
Sorry.
AR.
Okay,
Okay.
sir. My MS with AR, sir.
Best prognosis? Best prognosis?
MR, sir.
Both regurgitation lesions, both MR and AR. Okay,
Yeah.
there are this there is a pathophysiology which is going on in which it will not be decompressed. Okay, so they will be having symptoms only later. MR with AR. Here in our
Okay.
case, you say it is MS with AS. Then what will be the
Okay.
prognosis of these patients? Since here it is a dominant MS with AS, we cannot grade the severity exactly because of underflow, low flow. So what should be the prognosis of these patients, MS and AS?
Sir, poor, sir. Poor outcomes.
Yeah, poor. Low output. They have a very low cardiac output. Both are stenotic lesions. So they reduce the cardiac output. They will have all the symptoms. Since MS is there, back pressure symptoms. Since both MS and AS is there, forward pressure symptom also. Very less cardiac output symptoms. So the symptoms may be occurring very delayed, so that the patients will have a worse prognosis when we see such cases. That is the main thing.
Okay, sir.
What are the
So here the
complications?
patients additionally have pulmonary arterial hypertension also. That will also add to the prognosis of the patient. If the patient has developed how to grade pulmonary arterial hypertension in these patients? Well, not only clinically, you can say investigation wise also. How to grade pulmonary arterial hypertension? Grading of pulmonary arterial hypertension, investigation wise also. Echocardiogram you take.
Based on pressure, sir.
Yeah,
Pressure,
not only clinical examination, based on investigation also I'm asking grading of pulmonary arterial hypertension, because severe pulmonary arterial hypertension in any of the lesions decides the prognosis, whether this patient can be taken up for surgery or not, any replacement or not. So the pulmonary arterial hypertension in this case is very much important. Clinically, it looks like a severe pulmonary arterial hypertension, but grading by investigation like echocardiogram.
Yes, sir. Mild, it's divided into mild, moderate, and severe. Based on the right heart, like we can do right heart catheterization and we can see the pulmonary artery pressure, sir. Based on that, we can grade the patient into mild, moderate, and severe. Less than 20 is normal, sir. 20 to 40, 39 is 39, 40 is mild, sir, and 40 to 55 to 60 is moderate, and more than 55 to 60 is severe, sir.
So in this patient, clinically have a severe pulmonary arterial hypertension. That itself indicates the patient is having a severe MS. Okay.
Yes, sir.
Can aortic stenosis, pure aortic stenosis patient develop pulmonary arterial hypertension?
He told, sir, already he told that when he told.
Yes,
He
yes,
told.
yes.
So what are the complications, sir? So it's
complications of MS.
In this patient, what are the complications the patient can expect? This patient.
Sir, the patient is already in atrial fibrillation, sir. There is more chances of cardioembolic stroke, sir. Patient might go into cardioembolic events.
Then
may land into TA transient ischemic attacks.
Then
full-blown coronary vascular vascular accidents. Patient might go into cerebral vascular accidents. Infections. Infected endocarditis.
Common. You have not mentioned any regurgitation condition. Is it common?
Sir.
Infective endocarditis is more common with regurgitation conditions. Then syncope is the common is a common complication. AS, you told AS, so syncope is a complication. LV failure is a complication. Then CMOP is a complication. Then
right heart failure. Right heart failure. Okay, sir.
So, have you put the ECG? Yes.
Yes, sir. Yes, sir.
Other system you told me. And ECG, read the ECG.
Sir, left one ECG was.
Okay. It's okay, no problem. You read the ECG.
Yes, sir. So, no, patient ECG, 12-leaded ECG taken with a 10 mm 25 mm per second with a rate of about patient in atrial fibrillation, sir. With rate.
What would you look for in a case of MS? What would you look for in a case of MS and AS?
There is a left atrial enlargement we have to see in MS, sir. But
how do you find out MS? LAE?
We have to see P wave, sir. P wave and lead to. Is any enlargement of P wave and V2? Broad P wave, sir. But because the patient is having an AF, we can't able to comment on the P wave side. There's no option P wave side.
So you cannot say. That's what. Okay. You cannot
Yes, sir.
say. You cannot find a clearly reasonable preview. Then yes.
So
So
yes,
if
sir, we
it,
have
if it is in sinus rhythm, what would be the what is the criteria for left atrial rhythm?
sir,
Just
more than 0.12 seconds, sir.
for only lead 2 or some other lead.
V1 also here.
What would be the finding in V1?
There will be
Yes.
P mitral.
Yes. What is premature in V1?
There's a biphasic P wave, sir.
Generally, it will be by bypassing only V1.
Okay, sir.
How you be more specific or left atrial?
Sir,
Something else?
there will wide P wave, wide P wave, sir.
The negative deflection should be more in V1.
Sir. Terminal negative portion will be wide, sir.
What are the ECG findings of AS?
So there will be associated left ventricular hypertrophy. You have to see for left ventricular hypertrophy, sir.
Do you find anything here
This patient,
in this ECG?
yes, sir. There's in first ECG, it looks like the patient is having left ventricular hypertrophy.
Okay. What happened to the so before taking the second ECG, all the LVH changes have gone on. Have you treated the AS at this fast? Or do you find is the standardization correct in the second ECG? Did you look for? I'm not able to see it properly. So what are the various criteria used for LVH? Names and criteria. LVH criteria.
Usually we'll see lead V5 V6 R wave in a lead 5 lead R wave in lead 5 will be V6, sir, and tall S wave in V1 V2 and tall R wave in V5 V6, sir, which will be more than. We have to see which wave is larger in the V5 or V6 tall R wave, and we have to see V1 V2 which wave is deep S wave, and we have to combine the both, sir. It will give.
Okay. Is there any criteria named criteria? I'm asking
That's
the names.
Sokla line criteria, sir. The 35 mm.
Then
Voltage, cornell voltage criteria, sir.
what are the ECG findings for pulmonary hypertension?
Pulmonary hypertension, there will be a right axis deviation.
Then
right axis deviation. V1 R by, sir, right ventricular hypertrophy will be present, sir. Right sided leads will be R by S in lead V1 will be positive, sir.
If you find all R's in V1, then it's a clear sign of pulmonary hypertension. Okay.
Yes, sir.
Okay. Then
Right.
echo was done. Echo. Go to
yes, sir. Yes, sir.
Yes, sir.
Sir, echo AF was seen during study, RHD, rheumatic heart disease, with severe MS, severe moderate MR, aortic wall was calcified, aortic regurgitation was mild, aortic stenosis moderate, aortic stenosis pressure gradient 55 millimeter of mercury, tricuspid regurgitation mild, TRPG 60 mm Hg, and with severe pulmonary hypertension, sir. No LA or LA apical clot with ejection fraction of 60%, sir.
Okay. Chest X-ray.
Yes. PA chest X-ray PA view shows cardiomegaly, sir, with straightening of left heart border, with Cephalization of the pulmonary veins.
Then
Kerli B lines, we can see Kerli B lines are the
can be big lines. So here we cannot see because it's a slide. We can see. We can see only the
okay, sir.
in person only. Then we told about the cardiac failure. We told about the pulmonary. Some markings only. Then
Right.
what about the pulmonary arterial status?
Sir, sorry, sir.
Pulmonary arterial status. Defined any findings for pulmonary hypertension?
Yes, sir. There will be a prominent pulmonary arteries in the left.
Both left and right para, isn't it?
Okay, sir. Left and
Hilar
right.
trans.
Yes, sir.
How do
Hilar
you
trans.
quantify the pulmonary hypertension system? How do you quantify? Is there any marker?
In advanced cases, there will be pruning of vessels, peripheral vessels.
Then, what are the X-ray findings of pulmonary vascular disease? X-ray grading.
X-ray grading.
Grade 1, grade 2, grade 3. These LED lines will come in one grade.
Good. In severe pulmonary hypertension, Kerli lines will be.
What is the most severe pulmonary? What will you find in this?
Sorry, sir.
Next to Kerli lines, then what is the next grade for next next grade? Grade 1 is some sir Nata sir.
Yes, sir.
Grade 1, grade 2, grade 3, grade 4. I have.
Okay, sir.
That is some grade 1 is some inverted mush shine like that comes na. What are the grades?
Okay, sir.
Four grades.
Okay, sir. Okay, sir.
What are the grades?
Sir, I will read. I don't know, sir.
Okay. How will you manage this case?
Sir, initially I go with the investigation, sir.
Leave on investigations. Okay.
Yes,
Then medical management.
regarding management, diuretics. If patient is symptomatic, we can give diuretics patient. But for a patient is in atrial fibrillation, for the control of atrial fibrillation, patient will be started on beta blockers. For rate control, we will be using beta blockers, sir. To prophylactically, we can start the patient on anticoagulants.
Jawad, in this case, since both are low cardiac output states, both leads to low cardiac output states, stenotic lesions, diuretics can be given only to relieve the pulmonary congestion. But you should avoid over diuresis also because it can go for severe hypotension. Okay.
Okay, sir. Okay, sir.
Especially see AS cases, you should not give.
Okay, sir.
That will lead to syncope, sudden syncope.
Okay, sir. Okay, sir. Okay, patient will be like started on beta blockers as the patient is on AF and anticoagulants, sir. Most probably warfarin should be given, sir. The patient is having valvular heart disease with MS, severe MS. We have to start the patient on warfarin, sir, not on newer oral anticoagulants, sir. And we have to titrate according with INR, sir. And the patient, based on the severity, we have to decide whether the patient has to be referred to surgery. As the patient is after getting the valve area and severity, we can send the patient for surgery, sir. Surgery include for mitral valve, there will be percutaneous balloon mitral valve valvotomy, sir. And there can be open procedure, sir. Open procedure or closed procedure. Closed procedure through aortic through radial or radial sir. In balloon, we can first we have to actually classify the case, sir. Mitral stenosis. as patient has risk factors present, moderately severe, asymptomatic severe, and symptomatic severe, sir. If the mitral valve area is less than 1.5 centimeters square, the patient will be declared as severe, sir. If it's less than 1 centimeter, it's very severe, sir. Patient with very severe, we have to proceed with the surgery, sir. And severe with area less than 1.5 centimeters square. If the patient is symptomatic with severe MS, now you have to do surgery, sir. The patient is asymptomatic with reduced LV ejection fraction. We have to prefer the patient for surgery, sir.
Here the ejection fraction is normal now.
Sir, yes, sir.
So there is no question of low grade.
But patient is
Arun sir, may international options, sir.
I'm not getting you.
Yes,
sir. So international options regarding the management for this patient, sir, this particular patient.
This particular patient has both mitral stenosis, severe and moderate aortic stenosis. Because the severity of mitral stenosis possibly might underestimate aortic stenosis. So we have to be very careful in deciding on the treatment of aortic stenosis. And the indication for surgery in aortic stenosis, when you have another CABG or another valvular lesion, we have to go with a additional mitral aortic valve replacement also. So we have to do an angiogram in this patient. If there is an associated coronary disease, you have to plan for a double valve replacement with a CABG. If there is no coronary disease, means it's a straightforward case for a double valve replacement. And if the mitral tricuspid regurgitation is not very high, and the patient, if the patient is tricuspid is very high, and the right ventricular tricuspid annulus is more than 32 millimeter, means we can plan for a tricuspid valve annuloplasty repair, so that the right ventricular pressures are also taken care and the right ventricular enlargement is also taken care. So this is what my final intervention plan for this patient.
Okay, sir. Nata, sir?
Yes, sir. Yes, sir. For students to learn clinically, this case, for any case of aortic stenosis, clinically, the severity cannot be assessed in two conditions. One, when they have an associated MS or MR, mitral lesions, and another when they have a LV dysfunction. It is a low flow, low gradient AS. That is a clinical finding they have to say. It could not be assessed. Based on this one, since this is a case of predominant mitral stenosis, next valve involved is aortic stenosis. Sir said progression for next 5 to 10 years, they'll have developed aortic stenosis. Initially, if you have picked up the patient, you would have started on certain penicillin prophylaxis and would have avoided this aortic stenosis also. So it is better to look into it earlier stage itself. For this patient, what we manage medically is just a temporary phenomenon, but he will need a surgical correction. Anyway, clinically, you have to present what is the findings actually you got in this patient. You have to put. You should not cook up the findings based on the echocardiogram. That is a simple thing I have to say. What the echocardiogram may say, it may be different. What is the electrocardiogram may say, it may be different. But what clinically I have looked into it, based on the clinical findings put together, what is the most probable lesions you're going to deal with it? What is the probable explanation you're going to deal with it? That is what which is required of postgraduate level. Okay. You need not cook up the findings based on the echocardiogram. What I find out is you have put some findings which is not compatible with the clinical findings. That is what I feel. Okay. Javad.
Sorry. Thank you, sir.
Yeah, but it was a wonderful presentation. You have to understand, Thambi Javad, it was a wonderful presentation. You are not perturbed by any case, especially sitting over there or your professor. So it was wonderful for a young kid to present boldly, and it was very good. See, I'll never underestimate, even though as your professor says, there are some here and there, some corrections should be done, but overall it was wonderful to hear a free flow of your thoughts. And most of the times we are trying to discuss it in a better way. Maybe in the in a presence of an examination, you will be more integrated, because in online it's difficult. But hats off to you. Wonderful, wonderful, very good presentation.
Thank you, sir.
Chakravarti
Jawad,
sir,
it
your
was a
final.
it was a nice presentation. Jawad has come forward. He has presented boldly, and it was a nice presentation. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
Sir, Saravanan
Yeah,
sir.
yeah. And Dr. Jawad,
Sir.
yeah, can you hear me?
Yes, sir. Yes, sir. Yes, sir. I can hear.
Yeah. So basically this platform is meant for you people to make all the mistakes and try to avoid the mistakes in the examination. So don't
Okay, sir.
feel something wrong that you have made a mistake, small mistakes here and there. I would give you some sort of suggestion for you to prepare, go back home and
Yes,
start
sir.
taking the notes from the standard textbooks of medicine or cardiology and
Okay,
prepare
sir.
individual valvular lesions. For example, mitral stenosis. What are the classical features, expected symptoms and signs, followed by you try to understand or take a notes for the mild, moderate severity also. Similarly,
Okay, sir.
different lesions, hardly you have a 4 or 5 lesions you be thorough with exam point of view. And another point is similarly, the important common congenital heart disease also, you make a list of symptoms and signs and severity wise, how the changes will happen. Then
Yes, sir.
sit back and think about combination of disease. The common combinations like MS with MR, AS with AR, the common combinations, how the physiology or not physiology, hemodynamic changes happening or altered with the one lesion affecting the other lesion. Probably it's a high time for you to sit back and think about these possibilities. Then probably in the examination, you are anticipating probably questions raised by Arvind Kumar sir as well as Chakravarti sir. You will be able to talk in a very flow manner. Easily brain can analyze and come to an easy conclusion. Probably you didn't make yourself prepare for these combinations of disease or lesions and how the hemodynamic changes would have happened. Probably you're not able to answer few questions. It is a high time for you to sit back and start preparing the notes on this aspect. It's applicable to all the postgraduates. It's easy for you to answer the questions. Okay, I hope I'm clear to you, Dr. Jawad.
Yes, sir. Yes, sir. Thank you, sir.
Yeah, and just sit back and take a small notes. It's not very too vast time. It will take away small time and just sit back and start preparing from the
Yes,
standard
sir.
textbooks. Underline this. And another
Yes, sir.
suggestion to you is the exam point of view. Avoid using the abbreviations. Till
Okay,
now,
sir.
the postgraduate examination, every examiner is expecting senior most examiner or junior most examiner expecting to tell the full form of the lesions. Don't use, even though the faculty is also told about this, but it's very important that always from the exam point of view, to have a smooth sailing of an examination, try to go for complete words like aortic stenosis, mitral stenosis. Don't use JVP, jugular venous pressure or pulse waves, which you are meaning about, which are meant about this topic of JVP is concerned. So don't use these abbreviations, better to go for full expanded format. Otherwise, you
Okay.
presented nicely, and as everybody said, you got the what you call interest and enthusiasm of presentation. Need some sort of corrections here and there. Go back and start preparing on this. That's the basic idea of this platform, to make you to realize where do we stand, how much to improve. So just
Okay,
go
sir.
back and start preparing. You'll be able to better do the job in the
Yes.
examination day. Okay.
Okay.
Yeah.
Thank you.
Yeah. Thank you. Thank you. So thank you,
Yes,
sir.
sir. Thank you,
Natarajan,
sir.
sir.
Thank you.
Yes,
Thank
sir.
you.
Thank you, sir. Thank you, everybody, for your good
Yeah.
interactions. Thank you, sir.
Thank you.
Thank you,
Thank
sir.
you.
Thank you.
Yeah. Good night, all of you.
Thank
Yes, sir.
you.
Good night.
Good night.
Good night, sir.